Hello, and welcome to the Medicaid and CHIP Payment and Access Commission's Medicaid 101 series. Today we'll be talking about prescription drugs, but first, a little bit about the Medicaid and CHIP Payment and Access Commission, or MACPAC. MACPAC is a nonpartisan legislative branch agency that provides policy and data analysis and makes recommendations to Congress, the Secretary of the U.S. Department of Health and Human Services, and to states on a wide array of issues affecting Medicaid and the State Children's Health Insurance Program, or CHIP. MACPAC conducts policy research and analysis that is fact-driven and evidence-based. For more information, visit macpac.gov. This presentation is part of a series to provide educational content and highlight recommendations that the Commission has made previously. This presentation will focus on Medicaid policy for prescription drugs. We will begin with general background on prescription drugs, followed by payment to pharmacies for prescription drugs. Then we will discuss Medicaid drug rebates and end with an overview of Medicaid spending and cost containment. Let's begin with some background on prescription drugs. Outpatient prescription drugs are an optional benefit in Medicaid. However, all states provide the benefit. Under the Medicaid drug rebate program, drug makers are required to pay rebates. In exchange, states must essentially cover all outpatient prescription drugs. Later in the presentation, we'll dig into some of the mechanics of the rebate program. Generally, when we are talking about covered outpatient drugs, we are talking about prescribed drugs that are approved by the Food and Drug Administration and are typically filled by a pharmacy. In some cases, outpatient prescription drugs are administered by a physician in a doctor's office or outpatient setting. An example here might be a chemotherapy drug. The rebate program does not include drugs provided and billed as part of other services such as an inpatient hospital or nursing facility stay. It is also worth noting vaccines are excluded from the rebate program as well. As a helpful reference, we wanted to highlight the key drug provisions in statute and regulations. Notably, Section 1927 of the Social Security Act establishes the Medicaid drug rebate program. And on the regulatory side, Title 42, Part 447, Subpart I in the Code of Federal Regulations implements the drug rebate program and establishes payment requirements for drugs. Medicaid drug policy includes numerous acronyms. This is just a quick list of some of the key terms that we'll be referencing throughout the presentation. Now we'll move on to talk about some of the key actors and the transactional relationships in this space. When a Medicaid beneficiary gets a prescription filled, several transactions occur. First, the pharmacy purchases drugs from the drug manufacturer. This often happens through a wholesaler. The state or managed care plan pays the pharmacy for the drug, and the drug manufacturer pays rebates to the state or managed care health plan. States and health plans may also use a pharmacy benefits manager, or PBM, as an intermediary to negotiate rebates and pay claims. Today, we are going to focus on the transactions 2 and 3, involving the state and its transactions with pharmacies and drug manufacturers. This graphic shows all of the transactions that we just discussed. Over the course of this presentation, we'll go into greater detail on these transactions. Let's start with a discussion of how the pharmacy is paid. The highlighted portion of this graphic shows how the pharmacy is paid. Once a Medicaid enrollee receives a prescription from a clinician, they typically go to a retail pharmacy to get it filled. The pharmacy dispenses the drug and submits a claim to the state Medicaid agency. Depending on the state's policies, the enrollee may be responsible for a cost-sharing payment. There are two components to the state's pharmacy payment: the ingredient cost and dispensing fee. The ingredient cost covers the pharmacy's estimated cost of acquiring a drug. The 2016 Medicaid outpatient drug rule required that the state pay the actual acquisition cost for drugs. States have some flexibility in how they establish an actual acquisition cost, or AAC. This includes a state survey of retail pharmacy providers, or they may use the National Average Drug Acquisition Cost Survey, or NADAC, conducted by CMS. This national survey is the most common methodology. The dispensing fee is intended to cover the pharmacy's overhead and services to fill the prescription. This is typically between $9 to $12 per prescription. The beneficiary may also pay some amount of cost sharing, depending on the state. There are both federal and state limits on the amount paid to the pharmacy. There is a federal upper limit, or FUL, that applies to certain multiple source drugs and has been established at 175% of average manufacturer price, or AMP. The 2016 Medicaid drug rule made any federal upper limit that is less than acquisition cost equal to the acquisition cost. States may also have their own maximum allowable cost, or MAC, on certain drugs. There is typically some overlap between drugs on the FUL and MAC. States generally pay the lowest of these different amounts. This is a quick example of how these limits come into play. Let's assume an enrollee is prescribed a generic drug. The state typically uses NADAC, that Federal Survey of Retail Pharmacies, to determine actual acquisition cost and pays a $10 dispensing fee. In this example, the NADAC is $5. There is a federal upper limit of $4, and the state has the maximum allowable cost at $3.50. The pharmacy charges a usual and customary total fee of $20. So looking across the totals, you see that in this example, the state would pay the MAC and a total payment of $13.50. When a managed care organization, or MCO, is responsible for the prescription drug benefit, the payment transaction is similar to the state's, and they typically pay a similar methodology of ingredient cost and dispensing fee. Most MCOs do use a PBM to negotiate payment terms with pharmacies. Most notably, the 2016 Medicaid outpatient drug rule, which required states to pay actual acquisition cost, does not apply to managed care plans. MCOs are required to pay enough to provide sufficient access to its beneficiaries. This next section focuses on the rebates between states and manufacturers. The highlighted portion of this graphic shows how the state receives rebates from the manufacturer. This is an area where Medicaid is different from other payers. The federal rebate shown in the diagram is required under Medicaid statute. Under the Omnibus Budget Reconciliation Act of 1990, Congress established the Medicaid Drug Rebate Program, or MDRP. Under the MDRP, manufacturers must provide a rebate in order for their products to be recognized for federal match. In exchange, states must generally cover a participating manufacturer's products. States may limit use through policies such as prior authorization or preferred drug lists, but they must provide coverage of a drug to some degree. The federal rebate amounts are defined in statute based on AMP. Rebates are a separate transaction from the state's payment to the pharmacy. Rebates are also available on physician-administered drugs if payment for the drug is made separately and not bundled with the payment for the other services. There are different rebate formulas that apply to brand and generic drugs. For brand drugs, the rebate is the greater of 23.1% of AMP, or the difference between AMP and best price. There's an additional inflationary rebate if the drug's price has risen faster than inflation, as measured by the Consumer Price Index. There may be an alternate rebate calculated for some line extension drugs, such as extended release versions. This alternate rebate compares the inflationary rebate of the original version, expressed as a percentage, to that for the line extension, and takes the higher amount. For generic drugs, the rebate is 13% of AMP. There is no best price provision. The inflationary rebate was added for generic drugs beginning in January of 2017. Until January 1st, 2024, the total rebate amount, that is, the sum of the basic and inflationary rebates, cannot exceed 100% of AMP. After January 1st, 2024, the rebate amount may exceed AMP. The Affordable Care Act increased the federal rebate formulas, and the federal government keeps all of the rebate dollars above and beyond the old statutory formula. This offset applies to the changes in the basic rebate amount, which increased from 15.1% to 23.1% for brand drugs, and from 11% to 13% for generic drugs, as well as any increase to the line extension alternative rebate. This means the federal government gets anywhere from 0 to 8% of AMP for brand drugs, depending on where best price lies, and 2% of AMP for generics. The full amount of any additional increase due to the line extension provision would also go to the federal government. I won't walk through these numbers, but this slide provides some examples of how the rebates are calculated that can be used as a reference. It shows examples of different scenarios for the offset calculation for brand and generic drugs, which we will further describe on the next slide. This slide shows the results for the basic rebate calculation from the prior slide graphically. For brand drug A, the best price rebate is less than 15.1% of AMP, so the entire 8% of AMP is the federal rebate offset, shown in the dotted area. For brand drug B, the best price rebate equals 20% of AMP, which is in between the old 15.1% and the current 23.1% amounts. This means that only 3.1% of A&P, the difference between 23.1% and the best price level, is offset. For brand drug C, the best price rebate equals 30% of A&P. Because this is greater than the 23.1%, there is no offset. Because generic drugs do not have a best price component, the offset is always 2% of A&P. This slide adds on the inflationary rebate from the table on slide 23 to the prior graphical example of slide 24. The majority of states also negotiate supplemental rebates with manufacturers in addition to the federal rebates. Many states have joined together in multi-state pools to increase negotiating power. Manufacturers pay the supplemental rebates to have fewer restrictions on their products and increase their market share. The ACA extended the federal rebates to drugs paid for by managed care plans. They were previously only available for drugs purchased directly by the state. MCOs can also negotiate their own rebates, similar to state supplemental rebates. Any rebates that plans receive should be factored into the capitation rate paid to the plan. There are various data reporting requirements on states and manufacturers in order to carry out the rebate process. States invoice manufacturers based on utilization of rebate-eligible drugs quarterly and report this utilization data to CMS. Aggregate rebate dollars received by the state are reported quarterly on the CMS 64 Financial Management Report and used to determine the federal share of the rebates. Because of the timing on the invoicing process, there is at least 1 quarter between when the payment is made for the drug and when the rebate is collected. Manufacturers report required rebate data elements quarterly to CMS, such as A&P and best price. Rebate amounts for individual drugs are considered proprietary and are not disclosed publicly. While 340B is not a Medicaid provision, there are some interactions between 340B and Medicaid. The 340B program allows certain qualifying entities, such as federally qualified health centers, to purchase drugs at a discounted price. The 340B ceiling price is calculated using the Medicaid rebate formulas, and it is like getting the Medicaid rebate up front. Drugs purchased under the 340B program are not eligible for the federal Medicaid rebates, and states must exclude 340B drugs from the Medicaid rebate invoice. This prevents the manufacturers from paying double rebates. As mentioned previously, vaccines are not included in the MDRP, but vaccines for children are covered under a separate federal program established under the Medicaid statute, Section 1928 of the Social Security Act. Congress created the Vaccines for Children program to provide coverage of all vaccines recommended by the Advisory Committee on Immunization Practices. Children under 19 years old who are Medicaid eligible, uninsured, underinsured, or an American Indian or Alaska Native are eligible to receive vaccinations through the VFC program without cost sharing. Vaccines provided through the VFC program are purchased directly by the CDC at a discounted price and then distributed to the state, which in turn distributes them at no charge to registered VFC providers. These next couple of slides provide some data on the amount of Medicaid spending and rebates on prescription drugs and the tools that states have to manage drug utilization and spending. As seen on this chart, Medicaid drug rebates reduce gross spending, that is the payments to the pharmacies, by over half. Nationally, Medicaid spent about $80.6 billion in gross spending in fiscal year 2021, and manufacturer rebates were about $42.5 billion, which means that the state received about 53% back in rebates. Medicaid has some challenges in managing drug utilization and spending compared to other payers. Due to the mandated rebates, Medicaid has one of the lowest net prices of any payer. However, Medicaid cannot exclude coverage of a drug outright due to these rebate provisions. Nominal cost sharing in Medicaid limits the ability to change behavior and use certain preferred drugs over others. States are primarily using preferred drug lists, PDLs, and prior authorization to manage utilization and spending. PDLs are Medicaid's version of a formulary. Drugs on the PDL are subject to fewer restrictions than those that are not. Prior authorization are requirements that must be met, such as a certain level of disease progression, before the state covers the drug. States are required to develop the PDL using a committee of physicians, pharmacists, and other appropriate individuals. States also negotiate supplemental rebates in exchange for preferred status on the PDL and fewer prior authorization restrictions. Some states have started to negotiate a few outcomes-based contracts where the state gets a larger rebate if a drug does not achieve certain outcomes. Drug use review or DUR programs are required under statute to identify potentially inappropriate care. DUR includes prospective activities such as screening for drug-drug interactions before a prescription is filled. And retrospective DUR activities includes things such as claims review to identify patterns of inappropriate use, such as fraud and abuse or overuse. Thank you for listening to MacPack's 101 presentation on prescription drugs.